So thanks everyone for joining us. My name's Ash Clark. I'm Director of Research Operations. And I'd like to welcome you to the final online session for the Grampians Health Research and Innovation on the Run series. So just also like to acknowledge the traditional owners of the unceded lands on which we're all meeting today, and thank the world's oldest living culture for their continued care of land, sea and sky. Everyone's pretty good in terms of etiquette, so if you're not presenting, just keep your camera off and your mic off. We run a pretty interactive session, so just raise your hand or come off mute if you've got any questions for the presenters. We've got 4 presenters today, so we've got an extended 20-minute talk and then some of our rapid fire sessions to wrap up the session. So I will introduce our first presenter today. So Dave's unable to make it, so we have Stacey presenting solo on the Grampians Health multidisciplinary eating disorder service. Thanks, Stacey.
Thanks, Ash. I'll just share my screen. Hopefully everyone can see that okay.
Yep, that's good. Great.
Great. Awesome. Yeah, thank you, Ash, and to the research team for the opportunity to present. I'd also like to just acknowledge the traditional custodians of the lands on which I'm presenting today, the Wadawurrung people and their connections to land, waterways and community. Pay my respects to their elders past and present and extend this respect to all Aboriginal and Torres Strait Islander peoples today. I'd also like to recognise the individual and collective experience of those with lived and or living experiences of eating disorders, mental ill health and recovery, including their families, carers and supporters. As Ash mentioned, my co-presenter Dave sadly is enjoying himself on annual leave, so I'll do my very best to represent Dave and the whole team today, but a lot of this work did begin before I started working at Grampians Health. And I'm here to talk to you about the innovation of Grampians Health's eating disorder service, which is the first service of its kind in the region. So on the screen, you'll see the primary and secondary aims of the service, and the primary aim being a multidisciplinary eating disorder service for all ages in a regional non-tertiary health service, which incorporates integrated inpatient and outpatient care with smooth transitions from paediatric to adult care. This is a unique opportunity for us as a service, as other eating disorder services around Australia are generally not offering an all-age service. Secondary aims being increasing access for all people, care to be within a public health service, so no cost, and reducing the need for inpatient care by improving care coordination. The team, a few of us attended a conference in August in Auckland. It was the Australia-New Zealand Academy of Eating Disorders conference, and this slide was presented actually, and we were quite excited as a team to think about, whilst this is currently what's understood on offer across Australia, here in Ballarat it's not. You can see that second tier from the top, the local hospital interventions. We don't just offer medical stabilisation. What we offer at Grampians Health is much, I guess, more on the tertiary level of care and putting those 2 top tiers alongside each other instead. So a little bit of background on why and how we got here. I can tell you, as a nurse who trained in another regional town 15 years ago, the need has always been there. I remember being a grad nurse on a paediatric ward, and patients were admitted for weeks to months at a time. And, this was because outpatient care was unclear and they'd come in and out of hospital. Since then, a lot of improvements have been made with community mental health teams offering evidence-based eating disorder treatments for paediatric patients. However, because eating disorder treatment requires a multidisciplinary approach to care, there was still a need there for care to be more collaborative and cohesive. And everywhere saw this need go boom during COVID. Across the globe, we saw patient presentations for eating disorders increase by 200 to 400%. And this was, across the board, tertiary hospitals and regional centres. And you'll see here from the graphs highlighting the separations, Ballarat was no exception. We went from having 1 to 2 inpatients at a time with eating disorders on the paediatric ward up to half the ward being patients with eating disorders and severely unwell with comorbid mental health challenges too. So representatives from Grampians Health engaged politicians and consumers to present a business case, and in 2022 Grampians Health backed that need and committed to building an eating disorder service with some government funding to help see this dream realised. The proposal included a phased rollout, the first phase involving consultation. This looked like internally, of course, with all key departments involved, externally with stakeholders such as the Centre of Excellence of Eating Disorders Victoria, our tertiary centres within Victoria, such as the Royal Children's Hospital, Austin Health, Monash, Royal Melbourne. We collaborated with Barwon Health and Sydney Children's Hospital Network too. And this process set a foundation for us to develop our protocols and referral pathways to be evidence-based. As part of the consultation process, we developed our model of care, and our model of care guiding principles are the drivers to why we do what we do and how we do it. Treatment needs to be collaborative. Not one health professional alone can treat an eating disorder. It takes a team who are all on the same page, and treatment needs to match the intensity of the eating disorder, which includes step-up, step-down options of care, and of course needs to empower patients and their families with a recovery focus and really value the knowledge that lived experience brings. Phase 2 happened alongside phase 1, and I would say probably still is happening. And there's been some changes, I guess, from the initial proposal, but essentially what having these specialised roles within these departments means is we have a specialised multidisciplinary eating disorder clinic, which runs each Wednesday morning for the paediatric clinic and each Wednesday afternoon for the adult clinic. And these clinics have medical, dietetic, psychology, psychiatry and mental health. It offers assessments for new patients seeking diagnosis and also ongoing follow-up and review appointments for patients that are already linked into the service. And I guess outside of those clinic days on a Wednesday, there's also specialised dietetic appointments across the week, psychology or mental health, depending on the need. That all happens in the background too as part of the service. Our team works alongside the community mental health teams to deliver the eating disorder treatment psychological interventions. And I guess from an inpatient perspective, what this looks like is the care is more coordinated with a specialised multidisciplinary team which sees the patients each day. Previously, it would be a general medical team or the general peds team, which would rotate, and care would be more challenging in the consistency of care. So yeah, we now have regular inpatient multidisciplinary team meetings across the week, and this means that treatment planning is clearer for our consumers and their carers and families. So a little bit about who we're seeing in the clinics. From a geographical perspective, majority of our patients are local, which you can see here, 73% live within 50 kilometres. But we do reach out as far as 300 kilometres away, and we have options for telehealth for those consumers and their families. But we do hope to offer visiting clinic appointments within the regions in the future, because we do have quite a few families and consumers living within the regions. As far as the eating disorder diagnoses we're seeing in our paediatric MDT clinic, I've got some numbers here. Around 34% of OSFED or other specified feeding or eating disorder, 27% for anorexia nervosa, 14% for avoidant restrictive food intake disorder or ARFID, and 14% for disordered eating within other mental health comorbidities, or on the background of mental health and trauma. And then we've got 12% for atypical anorexia nervosa, and that's talking about, I guess, people that might not be underweight, but they have significant weight loss and all of the same physical and psychological risk of a person with anorexia nervosa, but they're often missed in the community because they appear to be of a healthy or normal weight. So we're trying to do lots of work for those consumers in picking them up earlier. And then 1% for bulimia nervosa and binge eating disorder. Comorbidities that we're seeing in the clinic largely is anxiety, which is around 44% of our consumers. Depression is around 20%, and neurodivergence around 13%. 15% don't have any co-occurring mental health conditions, and then a few OCD, PTSD, and BPD. Culturally, eating disorders do not discriminate. They can affect anyone from any cultural background. And here we see that largely we see mostly around 90% are Caucasian, but we have representation from a whole range of different cultural backgrounds, with around 4% being First Nations, 4% European, and 2% with an Asian background. As far as gender goes, we see high numbers of in the female population, and that's consistent with the data that the rest of Australia sees too. We do have high numbers of males in the paediatric clinic, so around 11%, whereas in the adults it's around 3.5%. And then we have about 1 to 2% for our transgender folk and 1% identifying as non-binary. Referrals here reflect, I guess, being within a public health service. This is something that wasn't offered before. So this will be a graph that will be good to see over a longer period of time. But I guess it doesn't reflect the mental health teams, the work that they were doing prior to the clinic starting to deal with the psychological component of care and treatment for eating disorders. However, we know that treatment for eating disorders requires a multidisciplinary approach. And I did a bit of a deep dive, and prior to the service commencing, consumers were having to fork out to see other private practitioners with significant costs associated with that, and care often being fragmented when they're having to visit multiple practitioners to receive care. So this created a significant barrier of access for treatment. Some patients wouldn't be able to afford that level of care, and they therefore just weren't getting the care that they needed. And becoming more unwell and likely needing inpatient care. But we're now offering a wraparound outpatient multidisciplinary treatment model. The green column here is highlighting paediatrics and the purple column is adults. But yeah, it'll be great to see this over a longer period of time. Are we keeping patients out of hospital? Positively, 73% of our patients seen in our service don't require admission to hospital, which is really good to see. Only 12% require one admission and 15% requiring multiple admissions. And these are our more complex and severely unwell patients. Our admission numbers, again, this would be great to look into the future and see over a longer period of time. But for now, you can see here our admission numbers are overall trending down. You can see a bit of a spike for adult admissions there circled in 2023. And meaning I think at the time the service was commencing, more people were getting help that likely weren't getting help before. Recurrent admissions are trending down, you can see, and that's with increased outpatient supports. And our first presentation admissions are also trending down, with our assessment clinic catching people at the start of treatment earlier and getting them linked into treatment, reducing the need for hospital stays. Here, the purple column shows our average length of stay for over our 18 consumers, and the green column is our under 18. So length of stay is overall trending down, with the average in paediatrics going from around 11 days down to 8 to 9, and adult consumers trending down from about 12 to 8 days. A part of phase 3 of the proposal is looking at infrastructure. Currently, we're operating out of outpatients on level 3 and 4. As the service grows, I guess this will be just an ongoing, look at where we operate from. But of course, also looking at service evaluation and monitoring what we're doing. So We're in the early stages of this part. We're collecting patient outcome measures in paediatrics. We're using the DAS, EDAQ and PARTY screening tools, and adults are using those and more, looking at quality of life and comorbidities. We'll be working alongside the research team, and lucky to have one of our dietitians also working in research to collate this data. We're also looking to do some exciting studies in the coming years. We've started working with the quality team on a project to hear the voice of our consumers and their lived experience to help evaluate the service moving forward. So watch this space. Phase 4 is really about, I guess, ensuring that treatment matches the severity of the eating disorder, which is one of our aims there, and guiding principles of model of care. Looking at more intensive outpatient options, so whether that's home-based or hospital in the home or day program options, and also, I guess, looking at how can we reach those in the regions and provide treatment closer to home. I thought I'd just include this slide in case people want to read a little bit more about the clinic. Please don't hesitate to reach out to me if you have any questions. The QR code here will take you to a medical assessment guide for GPs, which can be really helpful to give to consumers or clinicians to empower consumers to be referred to the clinic. And coming back to the aims of the service, I think we're doing pretty well at 18 months in. Excitingly, we still have a way to go to, but it's great to see that overall we've reduced the need for inpatient treatment and care's more collaborative with smoother transitions across inpatient and outpatient and paediatrics to adults. Thanks again for the opportunity to present today, and to all my colleagues across all the various departments, peds, medical, dietetics, psychology and mental health. The work we do is pretty tough and we can't do it alone, so we're lucky to have such a great team to do it together. Thanks, everyone.
Thanks, Stacey. That was great. We do have time for 1 or 2 questions from the audience, if there's any. Today, I actually have one. I was just curious. Oh, sorry, Andrea, you go.
Sorry, this is just a speculative question. We had seen this really big trend after COVID, trending very much upwards. Is there any thought that maybe this could disappear over time again?
Do you mean in general for eating disorders? Yeah, I think you know, it probably needs another couple of years to sort of see that downward trend. But I think we certainly, in the height of COVID and lockdowns, saw increasing presentations. And when you think about the comorbidities for our consumers with anxiety, it makes sense that it impacts their mental health and their development of an eating disorder in those heightened periods for everyone.
Thanks. And John?
That was a great presentation. I was just curious, did you say that the age agnostic aspect of the service was unique to regional hospitals? And if so, how did you how that seems like an interesting part of the process to build that in, and your external consultation must have been helpful in that. And I'm just curious about that part of it.
Yeah, thanks, John. I guess, you know, working with some of the tertiary hospitals, they're generally, you know, specialising in paediatrics, or they're an adult hospital without a paediatric ward or service. And I guess in other regions, I know Barwon has an eating disorder service, but I think they go up to 25 currently. And Monash Hospital, sort of along the same time, Grampians Health have been working to develop a all-age eating disorder service too, but they had a paediatric service prior to that. So I guess we're unique in the sense that it's all within the one organisation, with options, I guess, to stay within that organisation if needed and transition from paediatrics to adults.
That's awesome. And looking forward to the evaluation part of it, which will be of interest around the world once you're, because of that uniqueness.
Yeah.
Cool. Well done. Congrats.
Yeah, absolutely. I think echoing what John said, I think the importance of the evaluation and then being able to share that with the other services that are looking at similar models will be really influential. But thanks again, Stacey. That was great. Well done.
Thank you.
Now, our next presenter is Melanie Welsh. Just checking it. Melanie's there. So Melanie's topic for today is cost and... Oh, sorry, I've skipped ahead. I've missed one. Apologies, Melanie. I've missed Darlene and Sammy. My bad. Scrolled down too far on my run sheet. So our second presenting... There they are. Second presentation team is Darlene Cole and Sammy Russell, speaking about crisis mental health assessments and their scoping review. Thanks, Darlene and Sammy.
We'll unmute ourselves first. Everyone here is okay?
Yes, we've got your desktop though, which is shared. Oh, yep, there we go.
Got that.
Cool. And yeah, don't skip us, Ash.
We've been warming up for this.
We'll edit that bit out in the bloopers.
Good afternoon, everyone. Today we'll present our work in progress for our scoping review, looking at what are the mental health models of assessment for emergency departments.
Conducting a scoping review allows us to explore the evidence that has come before us.
So emergency departments have increasing numbers of consumers presenting with mental health issues. Emergency departments are overrun and not adequately resourced to provide appropriate care for mental health consumers. In late 2023, a mental health and wellbeing services working group comprising members from clinical, lived experience, leadership and administration formed to consider how current practice of assessment aligned with the challenges and also aligned with recovery-oriented frameworks and the recommendations from the Royal Commission into Victoria's mental health system. The working group provided a report to the Royal Commission Governance Panel in May 2024, outlining that current practices were met with several challenges and opportunities for improvement. The panel endorsed the next step of a scoping review in relation to mental health assessment to consider the evidence base toward a report and recommendations. So the Service Development and Innovation Unit, in collaboration with the Mental Health Research Officer, Sammy, and the Mental Health Social Work Lead, elected firstly to conduct a scoping review for crisis mental health assessments, focusing on models in the emergency department.
So the design of the scoping review has been done in collaboration with the LU team, and the research question itself has been co-designed. So for our methods, we've completed the first 4 stages of the scoping review process as seen here. We developed our research question using the Population Concept and Context, or PCC framework, and our final research question is, what are the mental health models of assessment for emergency departments? We then created a search strategy and searched 4 medical databases with our research concepts. These included Medline, CINAHL, PsycInfo and Embase. This search resulted in a total of 2,630 articles for title and abstract screening, which was conducted by our review team members acknowledged on the slide. Of these articles, the team then reviewed 84 articles in full text, and a total of 28 articles were selected for data extraction and appraisal. Once all of the articles have been extracted, we will then choose an appropriate risk of bias tool to appraise the articles. Then we will create a report for Grampians Health and also prepare a manuscript for publication in a relevant journal. So we have some preliminary results which report 2 models of mental health assessment that have been identified in the literature. And keep in mind that the data extraction is not complete and all of the articles have not been reviewed. So these results are not final nor complete. So briefly, the models that we have identified include the CARS model, which is a program for the management of suicidal behaviour and suicide prevention. The CARS program offers immediate attention to individuals presenting with any form of suicidal behaviour at the ED and follow-up treatment. Results report a reduction of suicidal behaviours after 12 months of implementation. The next model identified is the CAR model, which is an intervention for behavioural health crisis assessment, linkage and management to improve patient care. It offers a triage pathway, patient-centred assessment,
active crisis management, and 48 hours of psychiatric observational beds, which can then lead to inpatient admission if needed. It also offers referrals and linkages to other mental health providers. The CALM model reports a reduced length of stay in ED and the hospital and improved follow-up rates. The review team is currently working on extracting all of the articles for appraisal because this review is not finished just yet. So watch this space for our final results. And thank you for listening.
Thanks, Sammy and Darlene, and well done. Obviously opening up questions for the floor. Can I ask, while people are thinking of their questions, the review team, is that the first scoping review those staff had participated in? Yeah, fantastic.
Yeah.
Okay. And how has that process been? I mean, they're not here, so I'm asking you to answer for them.
It's been good. I just sort of took it from how I learned how to do a systematic review many years ago, and I just sort of created resources as best I could what helped me learn. And we had lots of meetings, almost weekly meetings, sort of running through the process of it, what is evidence in general, what to look for, and then I took everybody through designing the question and then putting together a search strategy, which I did on my own, and then we got all the articles and I taught everybody how to use Covidence. So we've been in and out of Covidence doing lots of meetings and lots of conflict resolution during the Covidence stage, and then now we're at the extraction, which is slowed down a little bit because extraction is quite a bit harder. But yeah, we're still on time. I think we started in June. So yeah, we were hoping to get some results by the end of the year, and the team has been really fantastic and jumped on board very quickly. And I haven't done a scoping review with this many people before, and it's actually turned out really, really well because everybody's jumped on and gotten it done. So it's been good.
Yeah, no, excellent. It's great to hear that, because I think that's the act of, it's not necessarily the results that the scoping review will bring out, which are absolutely going to be of use, but that process for actually doing the review itself, and it sounds like a real sort of learning and development opportunity, so which has been great, and it sounds like mostly positive experience. Yeah, very good. Are there questions from the floor?
Hey, great work, Sammy and Darlene and team. Be interested to hear that question from Darlene's point of view too.
You notice I was keeping quiet. Look, it has, it's been a really, for me, a great learning curve. I've got an interest in research and what it has to offer. Our space generally, obviously, there's not a huge amount of it being done in mental health in our service at the moment. So it's been great to be a part of that as a learning opportunity, sort of as Ash pointed out, and sort of gives you that whole new appreciation. And I'll keep even quieter about the extraction process. And when do I get a research assistant is the question.
Well, Sammy's asking the same thing, so you have to get in line. Hey, and really great work by the team. They've all pulled in, and fantastic job. And credit to both sides, both Sammy and also to your team. You guys have been amazing and getting in and doing the work. So well done. Hey, one other. I
was just going to say on that point, just in terms of the team, like I think it's one of those things that can bring people together with that shared and that common purpose. So, I guess the more that we see it in our space, people feeling like they're part of something that is, working on innovation and continuous improvement, I think is really exciting.
Yeah, fantastic. You guys, I think, have been an exemplar for that. It's been great. Hey, one other question. Sorry, Ash. So obviously this is about assessment and ED. There's no one from the ED team on, is there, on the review?
Not for the scoping review, no.
Oh, okay, all right.
And because I guess we were looking at sort of from our perspective, this is about the current sort of assessments that are provided by mental health clinicians. But I guess one of my interests is the where to from here when the when we present the evidence base and those opportunities for, you know, who we bring in as stakeholders and thinking about what's going to fit the needs of Grampians Health.
Yep, fantastic. Well done.
Yes, here. Well done. That was great. Thank you. Okay, now I've got it right. And now we will move to our third presentation from Melanie Welsh. And Melanie's topic for today is cost and fluid savings from syringe model delivery of intravenous medications. Thanks, Melanie.
Thank you. Oops, it's gone on the wrong screen. Just let me sort this out.
Yep, that's great.
Okay. So my role is I'm the medication guidelines and smart pumps pharmacist for Grampians Health. I'm based in Ballarat, and I was on this project basically forced in a way because of the fluid shortage that's been going on this year. So the aim of my project is to explore the potential cost and fluid savings from swapping the administration of intravenous medicines to the syringe module, which is an attachment to our pumps that we have in Ballarat. So in Ballarat, we use smart pumps, and as you can see on the right, that's the syringe module. And we have differing practices above the pump on our general adult wards. Some wards love their burettes and other wards prefer to add their medicines to IV fluid bags. But then when the IV fluid shortage hit, we needed to find ways to reduce our usage of IV fluid bags. So that's where that syringe module came in. Just for a way of illustration, when you give a medicine through the IV fluid bag, you would add the medicine into the bag and you'd need a second bag to then flush the line. And you would also need 2 different types of IV lines as well as your general consumables down there in yellow. Whereas with a burette, you would use 1 IV fluid bag and you can add the medication and dilute it in that burette chamber and then flush it with that same IV bag. And then you've also got 1 IV line that you're using. And to compare that to a syringe module, you can dilute and add the medication just into the syringe itself and then give it through a smaller, cheaper line, then just flush it with another syringe and a bit more diluent. So there's 3 different ways to give one drug, and that's what those 3 methods is what I compared in the project. So in phase 1, which was basically due to the fluid shortage, we looked at which medications are programmed in our pumps that would be easy candidates to swap over to syringe module because not every drug would work. And then we updated the safety software accordingly. We released an administration guide for each of the medications that were eligible, and then also ran some education sessions for nursing staff. So for our phase 1 of the project, we identified 12 medicines that were easy to swap over to the syringe module. And then that's just an excerpt of our administration guide that we prepared. In phase 2, we thought, well, what if we just kept this going? We were getting some positive feedback from some of the wards. So we looked at 1 medication called piperacillin tazobactam, or PIP-Taz. It's a broad spectrum IV antibiotic commonly used in hospital. And we're able to identify that it has a median course length of 4.25 days. And so I costed out the difference between the 3 ways of administering this medication. And as you can see, the syringe module ended up being the cheapest or the most cost-effective way to give the medicine. And that's mainly because of the IV line cost. And then also we looked at the fluid usage over 24 hours and found that the syringe module delivers a lot less fluid to the patient, and a lot less fluid is just discarded because it's expired before you could use it all as well. So there are a lot of assumptions, and it's a very simplistic scenario that I've generated, but what if we changed all PIP-Taz from IV bags to syringe module is the way that I calculated this out. And we dispense 7,400 doses per year in Ballarat. And if we were to swap from the more expensive way of giving the medicine, which is actually the more common way, to the syringe module, we would save up to 14,000 per year. And then in fluid savings, we would throw out 1,600 litres less per year. And there's potentially more savings. This is just 1 out of 12 medications, and it's data from Ballarat campus only. So the intended impact of my project will be to feed this back to the IV interest group that's looking at ways to align practices between campuses, then also to embed this into ongoing practice because of its cost effectiveness and its reduction in fluid waste and fluids given to the patient as well. And because this was just a very basic analysis, there are future research opportunities to do more complex modelling or expand it to more medications as well. And I'd like to just acknowledge all the people that helped me to do this project.
Thanks, Melanie. Gosh, there's next time around, I think you needed 20 minutes slot. I reckon there's a lot in this one. I've obviously questions from the floor, but I'm going to start with one. I'm really curious. So obviously this, the shortage precipitated this change. So what was the time frame? Because you mentioned you had your staff education rollout, and what sort of time frame are we talking about for that change or that recommendation change?
It took maybe about a month, which involved a lot of overtime. So it was something that was on my to-do list that I always wanted to do. But then I just took this as a catalyst and we were able to pull it together.
Yeah, fantastic. And what about, you also mentioned that you had received positive feedback from the staff after the change. So what was that? Yeah. Is that in relation to, is it easy? I was just thinking, is it an easier method for that? Like, what was the positive feedback in relation to?
Yeah, some of the nurses found that it's less steps in preparation for the medicine. And then it's just a smaller, more compact way of giving it. And other areas like critical care, pediatrics and Grampians Health at Home also are very familiar with it and they like it as well. So, yeah, I think that was the main thing, is just it's a bit more convenient for them.
Mm-hmm. Well, that's fantastic. Convenient and cheaper and less wastage. Often the simple changes can have very profound impacts, can't they? So this is very, very interesting. Are there questions from the audience?
I've got a quick question. So what happens in, say, like a metro hospital? Is it very similar to what we were doing? Or, are they using a different system? So I guess, what's the go out there that everybody else is using, I guess?
Yeah, a lot of metro hospitals have the same pumps as us. I don't think as many metro hospitals have expanded their use of the syringe module though. And historically, not many of us have many syringe modules to go around. So we actually got some through the state supply because of the IV fluid shortage to help do this. So I think there's probably a mixture of methods around in metro hospitals as well. And there probably always will be, because sometimes you have other medications running where it makes sense to have a different setup and not use the syringe module. So it's sort of, I guess, just a way of evaluating for your particular patient, if they only need this one drug, what would be the more cost-effective way to give it.
Thanks, Gemma. Are there any other questions? Okay. No. Thanks, Melanie. That was great. Looking forward to hearing more perhaps at next year's symposium as well. Thanks, Melanie. Now we're introducing Gemma still on the screen. So our final presenter, and probably a really pertinent topic to wrap up the Research and Innovation on the Run series, because Gemma's speaking about research outputs as evidence of research success. Thanks, Gemma.
I'm just having some issues sharing. Hang on a tick. There's no IT up here at the minute. So my share screen has gone dodgy.
Did you hear there was some glitches with the construction works and the Wi-Fi?
Hopefully it's coming. It says it's loading, but we'll see.
Yep, perfect.
I don't know what you can see. I don't know. Anyway, we'll just.
Yep. No, we've got it.
Excellent. Thank you. Excellent. So my name's Gemma. I'm the library manager here at Grampians Health. So basically, I guess we know that the health research landscape in Australia is diverse, and there's differences at state and federal levels, as well as variations between rural, regional and metropolitan areas. And we know that regional and rural health research often highlights unique challenges, such as limited access to healthcare services, workforce shortages, and higher rates of certain health conditions. And so the disparity underscores the need for targeted research and interventions to address the specific needs of those communities to ensure equitable healthcare across the country. So basically what the aim of this project was to look at what published research Grampians Health staff had contributed to, and then to look at which Australian and New Zealand standard research classification codes that they applied to, and therefore we would determine what our strengths and research gaps are. So what we did was a systematic review of publications from traditional health databases, so Medline, Embase and Sonal, and we looked at 2023 publications. So we used a combination of phrases and keywords such as Grampians Health, plus everything else that we were before Grampians Health, because we still have lots of different names out there. And then we also checked Google Scholar, because not everything is indexed in those main databases. And so the articles were selected only if they listed a Grampians Health or its previous iterations as an author's organisational affiliation. So basically we had 112 papers, and what we did was look at the field of research codes, and they were chosen as to what was deemed most applicable. So those 112 papers were basically added to an Excel spreadsheet, and then they were allocated 3 fields, because when you look at an article, it might be something about drugs that are used in cardiology. So obviously we can't just allocate one field to that, because, you know, it might be drugs, cardiology in the emergency department. So there would be 3 codes allocated to every single paper. And basically we looked at that to cover off the interdisciplinary research that happened, and it's also based on previous research that's been published. And also if you apply for grant applications at that federal level, you basically have to tell them what 3 codes you would be looking at. So we had 112 papers, 336 codes across 70 fields, which was 26 different groups. And so we have 27 different departments that published something last year. And we can see there the 5 most research active were oncology, allied health, infectious diseases, pharmacy and surgery. And so obviously if we look at this next slide, we can see the top 5 group codes. Obviously clinical sciences, no surprise, we do work in a hospital, were then followed by oncology, pharmacy, health services and systems, and then cardiovascular. And then if we look at that most popular one and break that clinical sciences field down, there were 14 different field codes. So obviously we can see there some of the big ones were things like surgery and emergency medicine and intensive care. So it's no surprise that those clinical fields rank the highest. And this slide here will show the fields that had 5 or that were listed 5 times or more. So again, we can see a mixture of those fields that are across, and we can see too that pharmacy was the most popular, I guess, for want of a better word. And obviously there are some other fields that are not listed on this slide. So obviously that included things like waste management, knowledge and information science, tourism, and social change, as well as library studies. So basically, I guess when we're doing this piece of research, highlighted some of the issues that pop up for research in regional and rural health. So things like the lack of funding. We also contribute to lots of research things. So we take part in clinical trials, or we have patients that are in those clinical trials. We give our data to things like clinical registries. And obviously those things are super important and we need to continue doing them, but we're not necessarily listed as a named author. Sometimes we're not even listed in, you know, depending on the publication or how they come out. We might not even be listed at all. So we are contributing, and I think that's really important to know, but it's not necessarily in black and white where we can see it. And then there's reporting issues. So as an organisation, we have to report in to IHACPA around what research outputs have been done, but they have very, very specific rules around what gets reported and what doesn't. So even though we had 112 listed, it would be less than a quarter of that actually get reported. And at the minute, that doesn't necessarily affect funding, but it's not to say that that won't happen in the future. So there's still lots of issues in that, research landscape that need addressing to make sure that we are also counted. But there are lots and lots of opportunities, I guess, that came out of this research. So obviously we have a fantastic cohort now of research staff, and allied health are shining examples. And I think that's true when we look back at what's happened over the last 5 to 10 years where there has been an allied health funded research position. So that really, really makes a difference. And obviously now we have some more funded positions. So we've seen already Sammy present today, for instance. So that will continue to grow. And then we have partnerships with places like the Western Alliance, and there's opportunities through that, like the STAR program. So there's some really, really good things coming, and opportunities available for us. And I think what was really pleasing looking at all the different things that we've done is that we are doing really, really great work, and we're doing it across a vast array of areas, and there's lots of collaboration as well. So that's really amazing. So I guess just in closing, health research is critical for understanding and addressing the specific needs of rural and regional Australia by improving access to care and promoting health equity. And it helps to ensure that health interventions are relevant, effective and sustainable for these communities. So lack of funding and lack of recognition for the work undertaken can impact smaller health services in their ability to undertake research, but it's hoped that this small study highlights the key role played by health services such as Grampians Health and others that are in similar position. Thanks.
Thanks, Gemma. That was really good. It's quite an interesting piece of work, isn't it? Because so for those that might not be aware, it's a very well-established process in the university sector around classification of research outputs, because that's a huge part of their funding model. So they get funding based on the classification of their outputs, but there's not many instances of health services looking at and classifying the research. And it's really good to see, because often when previously when we've looked at publications, as Gemma mentioned, you will get the author affiliation. So, if they're a pharmacist, it gets sort of put in the pharmacy bucket, but using that previous example as well, you actually can see that, no, it's both a pharmacy, cardiology and emergency medicine study, for example. So it really does, I guess, enable the highlighting of the multidisciplinary work. So it's been really, I quite loved it. I quite liked the graphs and the visual representation as well. I think it was a really well done piece of work. Are there questions or comments from the audience? Where to now, Gemma?
Well, I don't know. I've got a meeting with Anna who's going to tell me what I have to do next is my guess coming up. But I guess for me, it's a really great presentation to finish on, because I think, we are doing really, really well for a newly established health service. And I just think, there is lots of enthusiasm out there for research. So it's great to harness it through events and sessions like this. So great work from, the research directorates that are pulling all of those people and teams together. And it's really exciting. And I mean, I've been tracking our data for many, many years, and it just keeps growing every single year. So that's really exciting.
It's exciting. Very well said, Gemma. Yeah, Hannah, you don't need to put your hand up.
Yeah, I'm not normally that polite. Hey, yeah, great work, Gemma. So when you said we're doing really well for a rural regional site, can we compare to other sites? Is there a way to know how we benchmark?
Well, not necessarily. I just think compared to what we've had in the past, we are coming on in leaps and bounds. I don't know. I mean, I know I give some data to John that John then submits to IHACPA, but I don't know if that data is then publicly available. But that data is also dodgy because it doesn't include. So if you were second listed, it does, for instance, it's not counted. So you have to be the principal. So there's some really dodgy things that happen. But no, so I guess I mean I don't know whether there's somebody else out there that's doing this or not.
Yeah, you don't know, like in your network of hospital librarians, if anyone else is looking at their data?
Well, people do pull data, but they do it in a different way, I guess.
Yeah.
So because there's a lot of there's a lot of ways to slice and dice data. So I guess, and I think, it's very subjective, I guess.
Yeah,
So,
no, but interesting. And I know we have been improving year on, and great that you're tracking it because that really does show it. So well done.
Yeah, and I think just echoing in terms of the IHACPA data, that's a very flawed, as Gemma mentioned, it's a very flawed data set. So it really reduces or diminishes the impact of collaboration. And so essentially you can count as Gemma mentioned, you can count the paper only if you are the first named author. So it's not ideal in that manner. But it's a good question also, whether or not it's mandatory. I might follow up if it's published.
Well, and I was going to say also, like, for instance, the presentation that Sammy and Darlene gave, theirs also wouldn't count for the IHACPA data, even though someone from Grampians Health will be first named if it gets published, because it hasn't gone through HREC. So, there's all these rules and regulations that it has to have gone through, where research can happen at a systematic or scoping review level. It doesn't actually have to go through a human research and ethics committee, but therefore it won't be counted. So it's very, very flawed.
But it would be good, very topical, I guess, considering some discussions early today around benchmarking the organisation's activities. So very good. So thanks everyone for joining us. That wraps up all our presentations for this series. We've got a couple of pre-recorded and posters that will come out. I think next week they're due to come out. So we'll post an update in Thrive and they'll be published on the website. So really welcome you looking at those. The recordings for these sessions will also go up too once we do a little bit of editing and finessing. But thanks again. It's been really great. We've had such a fantastic depth and breadth of presentations and staff involved, which has been really good to see. And looking forward to seeing you all again next year. Thanks, everyone. Bye.